Okay, so through all of this, I've touched on point-of-care ultrasound, right? And so here I'm going to talk about it. I'm going to talk about it for vascular access, but also some of the other procedures that are going to be covered in the next unit. I think POCUS has become really the standard of care for vascular access, and a lot of other areas it's infiltrating more and more into our practice. And so this is an area I expect there's going to be more and more recommendations out of the boards. Right now, the American Board of Pediatrics is not mandating that people are doing POCUS, but several other boards have made that move, and I wouldn't be surprised that at some point that's going to happen within pediatrics also. So it's good to be aware of this. So let's go to a question. Which of the following is not true based on existing literature on POCUS in peds critical care? A, POCUS improves central venous catheterization rates. B, POCUS reduces central line complications. C, POCUS is a good way to diagnose congenital heart disease in a cyanotic newborn. D, POCUS is helpful in following the patency of a ductus arteriosus in newborns. And E, POCUS is helpful in thoracentesis and percutaneous chest tube placement. Okay, and the correct answer there is using POCUS to diagnose congenital heart disease in a newborn. Okay, so really that diagnosis is a challenging one, right? I mean, congenital heart disease can look a lot of different ways, in terms of the orientation of the heart, the chambers, etc. So that's something left to the experts, not really something that a pediatric intensivist should be doing POCUS, unless you're also a cardiologist and you also have your echo boards. That's a different situation. But for most of us, that we leave to our colleagues who have expertise. But all the other things, procedural complication rates really are much better with using POCUS, and so that's why we use it so often. And like I said, there haven't been American recommendations on this, but within pediatrics, the Europeans have already come out with a series of guidelines recommending POCUS in different situations. So I'm just going to summarize some of those. So the things that were given, basically the higher recommendations based on level A or B evidence, so RCTs or large observational data sets, were the use of cardiac POCUS to drain pericardial effusions, lung POCUS to diagnose and drain pleural effusions and to identify pneumothorax, vascular POCUS, particularly for IJs, but also for other central and arterial lines, and then cerebral POCUS to diagnose germinal matrix bleeds and to look at optic nerve diameter, which is a surrogate of ICP. I think the cerebral one is probably going to be the last one entering our practice. I don't see that done very commonly in some places, but certainly the other ones, I think at this point have become pretty mainstream in our practice. I showed this slide before just to show the different arterial line sites, but here I just want to focus your attention on the look of the point of care ultrasound, right? So the point of using the ultrasound is to differentiate the nerve bundle from the artery, from the vein, right? The vein should be collapsible. The artery obviously is not. This is not showing color, but you should be able to distinguish also based on color Doppler. Here I show you a short axis view of the IJ, and I think most people operate out of the short axis view. It's definitely the easier view to get, and here you can see, in the case of the IJ, the thyroid, the trachea, the common carotid, the IJ, right? So you obviously want to be aiming here and avoiding all of these structures. And so on these probes, often there's a little arrow to show you kind of where the midline is, and you want to put your needle there and ideally get your IJ in the middle of the screen to be doing that. Now, although this is probably the easiest way to visualize the vessel, and certainly what I think everyone starts out with, I think there's a lot of benefits to long axis views in that you can see the entire course of the needle as it's coming in, and you can see exactly where the vessel is. And so with short axis, you have the possibility that you kind of sideswipe the vessel. You go to the left or the right, and it's a little bit hard to see that using short axis. With long axis, if your needle and your vessel are in the same plane, there's absolutely no question that your needle is going to enter into the vessel once you achieve the right depth. But this takes a lot more expertise to maintain this view. And so this is not kind of the beginner view, but it's helpful for those who've done it for a while. Distinguishing artery from vein, as I mentioned, collapsibility, which you're seeing here in the video, and then pulsatility, right? So here you're seeing a pulsatile artery versus a continuous flow vein. Notice here, by the way, that the artery is blue and the vein is red. And this just has to do with the orientation of the probe and whether the Doppler signal is coming to the probe or away from the probe. So don't use red and blue to be your guide of artery vein, right? But it's really the issue of pulsatility versus continuous flow. Here's an example of use of POCUS in a pleural fusion. And so things that you want to pick out in a pleural fusion, if you're on the right side, you want to be able to see the liver and not get into it. That's a common problem. Diaphragm here, so obviously you want to go north of that. And notice here you've got a sliver of lung, and here the sliver of lung is pretty low down, but I've definitely had situations where the sliver of lung is higher up, and there you have to be cautious, right? Because if you're going to enter with a needle, you could spear it by accident. And so trying to find a pocket like this is like a dream come true. This is maybe like 10% of pleural fusions you see, right? But if you can get this kind of view, it's wonderful, right? Because it gives you a huge pocket, unobstructed, nothing bad to run into, and you go this way and you're going to get your pleural fusion. And notice that this effusion is not all that impressive on the x-ray, right? And that's just because there's a lot of fluid that goes into the posterior diaphragm and fills up before you ever see anything much on x-ray. In terms of paracentesis, very similar kind of view. There, again, you want to be able to see the intestines. You want to see a fluid pocket, and ideally those intestines are not bouncing up and down towards where your fluid pocket is. So this is an example of kind of a dangerous spot where there's not a lot of space between the bowel and the entry point. Here's one where you have a nice pocket, 4.5 centimeters, no problem getting in here. For pericardiocentesis, so this is not, I think, a common thing that most intensivists do, but you may have to do in an emergency, right? So I've done one of these in an emergency under ultrasound guidance just because no one else was around and it had to be done. And I think the important thing about ultrasound guided pericardiocentesis as opposed to the old-fashioned way, meaning by landmarks, is by landmarks, basically we went with C, right? You would go subxiphoid, you aim for the nipple. I've done a couple of those, right? And there you're just trying to get into the pericardial sac in an area where there's minimal risk of first hitting the heart and of also hitting other structures like the liver, etc. But you don't have any guidance. What you find when you put your ultrasound probe on, here you look at A, B, and C, which are basically parasternal and apical views. Sometimes there's a different view that's a better view. And really what you're looking for is a situation where you have kind of unobstructed fluid before you hit the heart and nothing else kind of bad that you're going to get into above the tissue, right? So this apical view here might be a perfectly acceptable way under ultrasound guidance to place your pericardial drain. But again, you wouldn't do this if you didn't have the ultrasound to help you. And so you definitely modify your technique with ultrasound guidance. Okay, so with that, we're going to wrap up our POCUS sessions and then move on to the rest of the procedures in lecture 2. Thanks for your attention.